Pain is one of the most common human experiences and one of the most misunderstood. For millions of people living with persistent pain, the real challenge isn't just discomfort, but fear, confusion, and the belief that something in the body is permanently broken. My guest today is Dr. Adriaan Louw, one of the leading voices in pain neuroscience education worldwide. Adriaan earned his undergraduate, master's degree, and PhD in physiotherapy from the University of Stellenbosch in Cape Town, South Africa. He is an adjunct faculty member of the University of Nevada, Las Vegas, teaching pain science. Adriaan has taught throughout the U.S. and internationally for more than 25 years at numerous national and international manual therapy, pain science, and medical conferences. He has authored and co-authored over 120 peer-reviewed articles related to spinal disorders and pain science. Adriaan completed his PhD on pain neuroscience education and is the director of Therapeutic Neuroscience Research Group, an independent collaborative initiative studying pain neuroscience. Adriaan is a senior faculty, pain science director, and vice president for Evidence in Motion. In this conversation, we unpack what modern pain science actually tells us about chronic pain, sensitized nervous systems, and why pain does not always equal tissue damage. We explore how education, language, and meaningful movement experiences can reduce fear, restore agency, and help people move forward with confidence and hope. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. Every Polestar graduate carries a unique story, a blend of curiosity, dedication, and a deep desire to help people move better. On the Live Aligned podcast, we highlight these incredible practitioners who are bringing intelligent movement into their communities. If you're seeking a practitioner who can support your whole movement journey, someone who understands the body, the mind, and the many factors that influence well-being, Polestar has graduates around the world trained in intelligent, evidence-informed movement. To find a practitioner near you, go to the Polestar Pilates website. Click on Find Your Graduate and search for a professional in your area. And now, my conversation with my colleague, Dr. Adriaan Louw.
Thanks for having me, Brent. It's nice to see you again.
And likewise, I always, I follow you behind the scenes, so you probably don't know how much I'm stalking you. But I love your work, and I love the combination of your work and my work in looking at the education and movement experiences combined as very successful tools for helping people process chronic pain. And, what would you say is a typical statistic these days for are adults that are experiencing chronic pain today in the world?
Yeah, that's a good question. Unfortunately, it's not good news. We now know that about 1 in 4 people in this world, that is not just America, by the way, is suffering with some form of persistent pain as the world is getting more access to things like phones and data. We're getting more data from, underdeveloped, if that's the right word, parts of the world. And that number is about 1 in 4, no matter where we go. And it's up. It's not getting any better, unfortunately.
Yeah, and I don't know that I would expect it to necessarily get better with a lot of the conditions and even just the stress and other things that we know are components that feed to it. Let's talk a little bit about types of pain and think of us as educating our common clients, maybe like an 8th to 12th grade reading level, to be able to understand the difference between nociceptive pain, neurogenic pain versus a chronic or nociplastic kind of pain that you've become quite an expert at educating. And I just wanted to say here as well, I think one of the things that I like most about what you've done, Adriaan, is the storytelling to communicate and relate to our listener, to the patient, of how they can also find a relationship of the kind of pain that they're experiencing and to be able to remove the fear of it and realize they're not alone. But let's start off with just some simple definitions of types of pain.
Yeah, that's a good question. And the easy answer today is I think people need to understand pain isn't pain. There's different kinds of pain, right? We often talk about pain in a linear fashion, where we talk about things like acute, subacute, and chronic, because it's tied to duration. If pain lasts a certain amount of time, we call it acute. And if it lasts a bit longer, we call it subacute. And then there's a definition that if pain lasts more than typically 3 months, we call it chronic. And that's okay. But I think the cool part about your question is that we can now take a pain experience and basically try and get a better understanding where is the information coming from that gives us the pain experience. So nociceptive pain, which is a fancy term for just saying it's our tissues, right? And the garden variety, you sprain your ankle, you walk out to your car, you sprain your ankle. We call it nociceptive, which is just a big old word for saying our tissues are basically sending the signals in that gives us our pain experience. So it's joints, it's muscles, it's tendon, it's ligaments, it's the aches and sprains we're very used to. So that's the easy one, right? And the nice thing about nociceptive pain is you know it, I know it. They tend to respond really well to the traditional treatments. Neuropathic pain, now there's neurogenic, neuropathic. In the simplest way, it's just our nervous system. So we have 45 miles of nerve in our body, and they work like an alarm system. And so there's nerves all over our body. We learned that in school, in biology, and in PE. The PE teacher talks about it. But there are nerves all over our body, and when they start waking up a little bit, we refer to them as neuropathic pain or neurogenic. Little slight difference, but the reality is our nerves are the main driver of it. And for our listeners, some of us may hear about things like radiculopathy, which is again another big word for just pain down the leg or pain down the arm when these nerves wake up, or carpal tunnel syndrome, where one of the nerves in our hand is a little bit irritated. So that's that bucket we see, and they're a little bit trickier to treat. They're a little bit more complex than the old sprains and strains. And then unfortunately, the more complex one is going to be what we call nociplastic pain, and this is when we have pain for a long time, and this is where our nervous system, this is all these peripheral nerves, 45 miles, plus the central nervous system gets a little bit way more sensitized to information. And we tie that to more chronic pain. So the pain is a little bit more widespread. It doesn't behave typically like we would usually see in nociceptive-driven pain. It's just more complex. But those are the three buckets. And by putting people into one of these three buckets, and again, we're not putting people in anything. It's just as scientists, as healthcare providers, if we know which one is driving it more than others, we can target our treatments a little bit better than we have been doing in the last heaven knows how long we've been treating people. Yeah.
Yeah. And I guess maybe a good question is, why do we have pain?
Pain protects. I mean, think about it, right? Without pain, we'd be in trouble. There is actually, unfortunately, a medical condition where people cannot feel pain. It's very rare. There's about 12 or 14 people in the world that have it right now. But you and I mean, Brent, if I break my leg, I need something to tell me go get some help. Pain is there to protect us. Pain is a protective mechanism. I know we don't like it. I don't think most people don't like it. But it's there to tell us you broke your leg, go to the emergency room. You stepped in a nail, go get a tetanus shot. But when pain does its job almost too well and too long, which we tie to persistent pain, then things are not fun. I think if I was a person in chronic pain or persistent pain today, and some guy with a funny accent on a podcast and say, pain is a good thing and it protects you, I would probably want to punch him in the arm because you live with it every day. But without pain, we'd be in trouble. That's the thing. Pain is a beautiful protection for us.
And I mean, people, like you said, that very small percentage of people in the, thousands of a percentage that do not experience pain don't live very long either.
Correct. They unfortunately don't. Correct.
Yeah.
Yep.
And I think that, if we unfortunately live in a society that has an expectation, Adriaan, of not having pain, like we should not have pain. And I think that just having some of this basic education of what pain is for and why we have pain. And as you said so eloquently, it's just like it's a protection mechanism. It protects us. It forces us to take action. Another question that I always like to answer, and I'd love to hear your thoughts on it, is pain in any way indicative of the amount of tissue damage? Like, is there a direct correlation, or does it, fluctuate based on the person, the experience, the belief models, et cetera?
Yeah, I appreciate that soft toss. No, I mean, the reality is we were taught traditionally. I mean, I went to therapy many years ago, and I was taught that if you sprain your ankle a little bit, it hurts. If you sprain it more, it hurts more. And if you sprain it really bad, it hurts a lot more. And that's not true. If you think about, for example, a paper cut, in the essence of a tissue injury, it's one of the most benign, horrible things, but it's one of the most horribly painful things you've ever had. So it's way more complex than that. The reality is tissue health and pain is two different things. There are people with beautiful, healthy tissues on scans that hurt really bad. And there are people with yucky tissues that don't really hurt that bad. I'm in Iowa, and it's harvest season right now, and I can tell you there's farmers out there with some really yucky tissues right now for harvesting. And I'm not downplaying people's experiences of bad tissues or not bad tissues, but they're not correlated. Not as much as we always said. How about that?
Yeah.
So no, they're not.
I love that story from Lorimer Moseley, where he talks about going for a little walk out in the bush, and he talks about how he bumps up against something, and the next thing you know, he's being medevaced for a snake bite. And then a couple years later, he's back out in the bush walking, and he has something that bumps his leg, and he has excruciating pain, and he thinks he's dying. He falls down. They pull up his pant, and he had a little tiny scratch, from a plant, part of the bush. And I love that analogy, because I think if we understand the purpose of pain that you defined, right, it's a protective mechanism. It should drive us to take action. And what I loved about Lorimer's story is he talks a little bit about where the messaging happens and how the historical part of the brain is scared of anything that brushes up in that part of the leg because of a near-death experience with a poisonous snake. Explain a little bit of that to us, like why do we have these different experiences based on our history or our beliefs that something could be so minimal and be so painful, and maybe how that leads into, the neuroplastic kind of pain or the centralized pain?
That's a really good question. Pain is complex. Pain is not just a simple message that comes into our spinal cord to our brain. So it's a very complex process. First of all, we are a product of our history. The biggest predictor of back pain is if you've had back pain before. It's almost as simple as that. We remember things, right? But to answer your question straight up, for the longest time, we believe there's a pain center in the brain. So if I were to sit next to Brent right now and I punch him in the arm and we put his head in a scanner, we would find a little area that pops up and said, pain. That's not how it works. I always tell people this. Imagine if you had to close your eyes for a second and think about your grandma. Your grandma isn't a little area in the brain. You can remember her. So your memory area had to get busy in your brain. So when we put you in a scanner, the area of the brain that deals with memory gets super busy on the scanner. But you also see Granny. When I close my eyes, I can actually see my grandma, right? So the visual area gets busy as well. So now there's two areas that are busy. But then also there's feelings. I miss my grandma. I haven't talked to her for a while. So that area of the brain gets busy. So when we have an experience, grandma, pain, the reality is multiple areas get busy. And so when the memory areas get busy, we remember a lot of different things. And so in Lorimer's case, a great example is he had this horrible experience where a snake bit him, which those are very bad snakes in Australia, by the way. Now that the minute something got even close to it that resembled that experience, that map in the brain, that tag, if you will, lit up instantly. And the end result, the conclusion was, this is bad. And the most powerful thing that could happen for the brain to get your attention is turn on the most vicious pain that he could feel, even though it was a twig that was scraping his leg. So it's a very distributed process. And so to finish the question, in chronic pain, our brains just get busier with pain because we go to doctor's visits, therapy visits. We're not getting any better, really. And so the brain gets more worried. So it says, let's talk some more about it. Let's talk some more about it. And so our poor patients come in and say things like, I cannot focus as much as I used to. I could read a book front to back. Now I read halfway through and I'm tired. Or I got that fog in my brain. There's nothing wrong with the brain. The brain is just busy and is dealing with pain, there's no pain area in the brain, so the brain gets busy in the other areas. So very fascinating. It's hard for our poor patients because memory goes down a little bit and focus goes down, but it's a consequence of being busy with pain while we're dealing with pain.
What would be an example of a story that you would tell to explain to a patient that's dealing with that?
Yeah. Oh, absolutely. There's a beautiful story. We like to tell the brain meeting story, right? So just like I did with you, Brent, I will sit with the patient and say, hey, did you grow up with your grandparents? I say, oh, yeah. I said, all right, I want you to do me a favor, close your eyes and think about your grandma. And they close their eyes. And then when I say, open your eyes, I say, can you remember grandma? Yeah. Okay, good. Did you see grandma? Yeah, when I close my eyes, I can see her. Do you have any feelings, right? The same thing I did with you. And then I will explain to them and say, there's no one area in your brain. You had to remember grandma, so the area of the brain dealing with memory is busy. You had to see her, you had to smell her, you had to experience her. And that is how pain works. So think of the brain this way. There are 9 departments in the human brain. There's a movement department, there's a focus department, there's a memory department, there's 9 different departments in this big thing called the brain company. Every department, when it's fully staffed, has 4 people working in that department. So if I, as a therapist, ask you to raise your arm in therapy, the department that deals with movement is fully operational. So you raise your arm beautifully to the top and bring it back down, and we're good. But when you have pain and the brain, there's no pain department in the brain says, okay, we're going to have an emergency pain meeting tomorrow. Why? Because I've been going from doctor to therapist, MRIs, CAT scans. So now, because there's no pain department, the brain says, I want one person from every department to come to the pain meeting. So now the movement department, instead of having 4 people, have 3 people. So I ask you to move your arm in therapy, and now you move kind of ugly, if you will, kind of like wonky, right? And doesn't mean there's something wrong with you. No, that department is understaffed. Now your brain gets tired when you read a book. Why? Because the department is understaffed. And so the cool thing is we can also shift it. The more I teach you about pain, the better we work on sleep and nutrition and all the good stuff we're supposed to do in therapy, we can actually get those departments to restore. But it's plasticity. It shifts. It can get a little bit more busy. It can get less busy. But yeah, those are just as an example, and it seems to resonate with people. They go, oh, that makes sense.
I love that story, and it resonates with me. I mean, I think that, I can totally relate to the idea of overly busy, understaffed, and feeling that exhaustion that so many patients have. And I think that for those of us that are physical therapists and practitioners and doctors, we don't realize how our language and the things that we say to our patients impact the busyness of their brain. That's going to happen because of what we said. We're an authoritative figure. We make statements. We say things. We use big words. We throw out things like, well, it looks like fibromyalgia, or it looks like this or that. And, it scares the crap out of the patient. And now their brain gets busy. And they got, like you said, they go get a lot of tests. They go get imaging. I had John Sievert, a good friend of mine, was on another podcast with me, and we were talking about, the idea of imaging and having somebody, a radiologist, go through and list everything, every wrinkle that's inside of us that potentially could be causing it. And one of my pet peeves, and I've talked to a lot of radiologists, is if I can tell you what I'm trying to rule out, can you look at the imaging from that perspective rather than writing down every single thing that's wrong? And the radiologists love that idea because they're just trying to cover their backside in their interpretation, but they often have no idea what the patient is in for. They're told to do a lumbar MRI with contrast. They're not told, let's rule out a L4, L5, discogenic symptoms on the right side, which might be a lot easier for them to do. But that being said, the patient then gets a test that comes back and has all kinds of things wrong with it, with a practitioner who is a surgeon. That's what they do, is surgery. And we're not necessarily communicating apples with apples. And so we create more fear. We create more busyness in the mind. And one of the areas that you and I have collaborated a little bit is the idea of creating these successful movement experiences as physical therapists and movement practitioners in conjunction with good storytelling to de-sensationalize what's going on. And that education is such a powerful piece. I'd like to hear a little bit about you, what you're working on right now as far as integrating the idea of physical therapists being able to create these successful movement experiences in their therapy sessions at the same time that they're creating that beautiful education experience, especially for patients with chronic centralized pain.
Yeah, a big part of our work, a big part of what I'm trying to do is obviously get the next generation of healthcare providers to take this on, this idea that there's this beautiful thing called pain neuroscience and pain neuroscience education, but also that in itself is not that helpful. I've never explained pain, if you will, out of this person. I've never sat with a patient, teach them so much about pain, they sit up and go, oh, I'm pain-free. What it really just does, it makes them less fearful. And when they're less fearful, they move better. And as a therapist, that is obviously music to my ears. So what a lot of therapists, a lot of healthcare providers don't know, I mean, movement is critical. The evidence supports so significantly that movement helps pain. The problem is just when we move, we hurt if we're a patient. And so they're sitting on the other side of this podcast and go, but you don't understand it, Adriaan, when I move, I hurt. But they don't understand also that there's behind them, there's a nervous system that's sensitized. So by teaching people, we reduce the fear and they go, okay, I got it. I hurt, but I'm okay. I'm sore, but safe. Hurt doesn't equal harm, so they can reappraise that. They still have to do the exercise, they still have to do stretches, because that's ultimately what's going to make them better. And so, unfortunately, Brent, in our world, a lot of clinicians were taught the movement stuff, and they should, by the way. That's the definition of therapy. But this little piece is, and what's so cool about it is that people are beginning to take it on. So when therapists come to seminars, conferences, and they just see this piece, like, oh my gosh, I can do this cool thing about teaching people about pain. They understand it better. Their fear goes down. Now they move. So I'm going to facilitate the movement in the clinic, get them going, and then we slowly over time pace them to where they can go do it at home. But that's really the model, and that's kind of what we're working on heavily. I teach at a lot of schools as I travel around PT, MD, DOP, PAR, and OT. I mean, that's the mission. The mission is to empower the next generation of healthcare providers, which, by the way, hopefully if they get this, they will be 20 to 30 years ahead of me when I graduated, and that would be a great place for the profession to be at.
Yeah, and I'm on the other side of that, teaching the successful movement experiences and always mentioning the pain education and the idea of, like, can I meet the patient where they are in a successful movement experience? Can I educate them that pain does not necessarily equal tissue damage, and that anything we're doing is basically restoring some functional movement that they want to return to, that they believe they can return to, by us creating these positive movement experiences. And I'll often tell people, this is the beauty of Pilates, where I can be in an assistive environment, I can create foreign environments of movement, I can create modified movements because I modify the length of the lever or the amount of resistance or the degree of the base of support or those kind of things. But the goal is really can be done anywhere, and this obviously is a neuro rehab concept of us looking at how do we do graded load, how do we create these successful movement experiences, how do we make these experiences relate to them in a functional way. If people think that it's about strength, they're probably barking up the wrong tree. It's are they able to see themselves getting out of a chair without severe pain? Are they able to see themselves walking up a couple stairs without pain? Are they able to see themselves reaching overhead in an airport or in an airplane? Are they able to see themselves feeding themselves without pain? And that becomes such a crucial part of what we're doing from the diagnostic to the prescription, is creating these successful movement experiences that exceed their expectation. And again, it goes back to this plasticity part of it, is like, if they are triggering very early with non-damaging forces, how do we gently move into that space and reduce the fear, create the experience, and then come back and say, what did you feel with that? Like really being able to have that discussion with them. I'm curious in the efforts you're doing, and everybody knows who Adriaan Louw is in the physical therapy world, and I think that's a very good thing. This is an area that we don't spend enough time in our education. I teach at a couple universities as well, and then guest teach at many other universities, and it's an area that we're so desperate to push our students through to be able to sit for their exam and pass their exam. We want to look good as a university. We want to, have a high pass rate. And yet we see that in an industry where 1 out of 4 people is going to be dealing with chronic pain of some sort, are we really prepared to be able to assess, diagnose, and prescribe an intervention based on these principles of pain education and successful movement experiences?
Yeah, it's again a loaded question, right? I just want to, for clarity, people need to understand that the role of an academic is to make sure a student passes a test, because if they don't pass a test, mom and dad's aren't going to be happy and those kind of things. But to answer your question, though, Brent, I joined this pain world in 1996 is when I really got into the pain stuff. And somebody told me those days, hey, there's a pain revolution. And I remember looking around like, I got to find this thing called pain revolution. Never really found it. I found a couple of zealots sitting at some conferences in the corner because nobody would talk to them. I truly believe, as I'm doing this discussion with you today, there is a pain revolution. It's happening at scale. The CAPT that sets up the PT curriculums for PT school have adapted the guidelines from the International Association for the Study of Pain. ACOTE that sets up OT schools have done it similarly. We are getting ready to basically turn a next generation onto the pain stuff. Do they have to be zealots in pain? No. But if they have this base knowledge, I think it happens. You would know this, but in the old days, people like us, the pain people, were invited to the big old joint muscle tendon conferences once every 10 years. We would say, oh yeah, there's pain. And now we're front and center. So there's definitely something happening. What excites me is we're getting more and more workshops where we have our physician colleagues are joining us, the PAs, the nurse practitioners, because the reality is they don't know either what to do with them. And I'm not having a go at them. I work with them every day and they're brilliant. But my pain docs will tell me, Adriaan, when I've done my series of injections, I've tried a couple of things, I don't know what else to do for them. And so this is not easy. There's nothing easy about it. But to answer your question, I do think there's a change. I see the change. Oh, and by the way, the next generation is way more into things that we never had, which is nutrition and sleep and yoga and stuff. I mean, we didn't have that when I went to school.
Yeah, we've certainly seen that as well. The testing aspect of university of getting out is usually about 10 years behind where the science is. And that's, and there's really no way around it, but it is bringing this in. And I'll give you a short example too. Like I teach professional formations at University of St. Augustine. Well, in that class, I've taken advantage of communication skills at a much more advanced level, like really getting the students capable of asking questions and seeking to understand and putting their internal biases away and being able to hear what the patients are saying so that they can provide the proper education to them. And you're right. I mean, this is a course now finally, after squeaking for so long, this is the third term that it's being offered at St. Augustine. And so we're seeing this in a lot of new curriculums. CAPT certainly wants to see it. We know now that it's part of our curriculum, and I do think we're going to see more and more of it. What I'd like to do is just shift gears a little bit of thinking of the consumer that's listening to this as well is, what should a patient that is dealing with pain, what should they be looking for in their practitioners, in their physicians? How should they process the information coming to them if they were, let's say, your client or your family member that lives somewhere or some other city? What kind of advice would you give them when they're searching to be able to manage a chronic pain episode?
Yeah, again, just a great question. My mentor, David Butler, told me years ago, a person in chronic pain needs to own their pain. And it wasn't negative. I always tell patients it's your pain. You own it. And you need to seek somebody that will basically treat you with respect and dignity. If they don't, you fire them. And that includes me. If I don't treat you well, you need to stand up and say, you don't deserve me as a patient. That sounds very arrogant or whatever, but the reality is you need to go find people. There are healthcare providers that really get the pain stuff and they will work with you. There's those that don't get it. And by the way, I was one of them for a long time. I was one of the I don't get it. So I was probably on the other side. So it's no different. I mean, I think the reality is go find somebody that you can connect with really well. They meet all the criteria that you need. But on the flip side, also just get somebody that will keep you accountable. I think that's important. If I want to train for a marathon, I want to get an accountability partner and say, hey, Brent, we're going to run the Miami Marathon together, and you and I come rain, shine, doesn't matter. We're going to Sunday mornings at 6 a.m. We're going to meet for a long run. But I want to get somebody that's going to keep me accountable. Hey, dude, you need to be there, right? So it's a little bit of that. But I would just say, find people that care, and there are many of them out there, and basically just, stand up for yourself in many ways. I think a lot of poor patients find themselves in a scenario where they just, this is where I am, there are very good providers, yeah.
Yeah, another thing we see from a behavioral psychology standpoint is the difference between an external locus of control and an internal locus of control. So a lot of people in chronic pain, not all, but many, have an external locus of control. They feel they're a victim of something, or of the system, or of an accident, or of a disease. And like you said, one of the things we educate is to have internal locus of controls, like take the responsibility, own it, but at the same time, own the responsibility of finding the right practitioner that listens to you, that you can work with. And I would just like to add the 2 cents to it, is that you're looking for somebody that is going to help you in the process of taking that responsibility and being active in managing the pain rather than passive. And I think the more educated you get, the more that you can make decisions of getting better sleep, getting better nutrition, having the right kind of practitioners, finding doctors that will listen to you. Doesn't mean you're not going to receive external care. I just went through a back surgery 5-6 months ago and had great practitioners that did listen to me. And this was the decision we made collectively, with me having the autonomy as the patient, being able to make the decision because I was given really good information from multiple practitioners that pointed to what was going to be the best option for me to make that decision and get better. And it's been successful. And I just, having gone through it for myself, I see even more how empowering it was for me to take the responsibility to find the solution, but also that solution was finding really good practitioners who would listen to me and could talk to me, and we could work together and find out what I needed to do for my best self.
Yeah. Brent, you make me think of something very important. If I was a patient listening to this right now, I mean, this sounds all interesting and et cetera, but why are our patients where they are? Well, first of all, we've done a really crappy job helping them. So if I was a patient on the other side, we have done poor. And I think today you and I both owe patients an apology as part of the healthcare system, right?
Yep.
I will acknowledge that today. We've done a real crappy job for you, sorry. But I want people to know, if I was a patient listening to this today, number one, I want you to know there are people trying. They're trying very hard. I hope everything I know today about chronic pain, that's the area that I specialize in, that it's different in 5 or 10 years because we're learning. Here's the neat part. Many of the stuff that we're studying right now is mind-boggling. It is absolutely fascinating. This brain that we talk about, the brain in pain all the time. This brain has 125,000 miles of wiring in it, gets replaced every 3 weeks. The nervous system itself, this alarm system, replenishes itself every single day. It changes around. The term neuroplasticity just refers to the fact that our nervous system, our brain rewires itself, which means things don't have to be status quo. Or as a patient would tell me in the clinic, you mean this can change, Adriaan? Yes, ma'am. So there's hope. I want people to know that 40 years ago, we just believed your brain is the way it is, take it or leave it, that's it, and it's total garbage. Our immune system shifts. Our gene expression shifts, our brain shifts. And what it would mean for somebody that's been struggling with pain for a long time and say, Adriaan, there's no hope. I've tried everything. I strongly would just tell you guys, Find somebody that can help you, because these things can change. It takes work, absolutely. Losing weight, it takes work. Stop smoking takes work. Getting moving with pain, those things. So it takes a little bit of work, no doubt about it. But if it's one thing I want people to know is that there is hope. Everything we thought there was kind of, well, that's kind of the way you are, they shift, and they shift very, very powerfully, by the way.
And I think this is, probably the most important message that people could take home is the concept of hope, where I was in the same training. I graduated in 89 and was told that there was no neuroplasticity. It was like that you are going to lose neurological cells every year until you no longer have functioning neurological cells. And so when you dealt with somebody that had a neurological impairment like Parkinson's or a stroke or MS, it was always like there's no hope. And the joke was for the neurologist, diagnose, adios. I'm going to give you a bad diagnosis. I'm sorry, see you later. And we've come so far. And we're coming more far. I think just the fact of talking about telomere change based on lifestyle and behavior in the genetic expression is huge. And when we look at the history of treatment that we did for pain, we certainly had a real ugly period where opiates became the primary source of dealing with pain that led to a lot of severe cases. We don't need to beat that one to death. But I think also looking at when I would go to pain conferences in the past, the majority of it was being sponsored by pharmacologists and pain doctors that were talking about injection techniques and how much is enough and how much can somebody's system tolerate of pharmacological interventions. We already were seeing, though, and the reason why we were invited was because we are having success with chronic pain in the method you're talking about. And part of the goal of the pathokinesiology work that we're doing is what the Live Aligned podcast is built on, work from Dr. Helen Hislop years ago of saying, our specialty is the impact movement has on pathology and vice versa. And we know that as physical therapists, our jobs consist of education and movement and returning function. That's our primary goal. It's something that's incredibly unique to us as well, to be able to move people when they're in a pathological state, whatever it is, neurological, autoimmune, it doesn't matter. Our job is to try to get them to restore to function, which is a very unique calling. And what I want to bring out a lot in this, and we've already expressed it, is the power of education as it pertains to something that is one of the greatest deterrents of movement is pain. I would say nausea probably is the number one, but I would say that, like with a vestibular disorder or something, but pain is way up there. And how we deal with that becomes so important. What I'd like to do now to finish up is, you and I could talk about this for hours, but I'd love to pull a diagnosis that is quite common in our world today regarding pain that I believe is often misunderstood and can greatly benefit from the education you provide, the successful movement experiences we have. We still have a lack of understanding of this. It's more of a syndrome, but that is fibromyalgia. So we still have a lot of people walking around with diagnoses of fibromyalgia. I would love to hear your impression of it. I would love to hear sort of what your thoughts are for those that are listening that maybe are carrying this diagnosis with them. How do we remove the fear of this diagnosis, restore some hope, and where can we go from here with our role as physical therapists?
Wow, that's a loaded question, right?
Always loaded questions.
Well, first of all, I just want to make the basic statement that if I was a patient on the other side with fibromyalgia, I just want people to know I do not have fibromyalgia. I can only fathom what you're going through. I've worked with thousands of people with fibromyalgia. I've trained a lot of therapists that have. If I currently have to peel everything away from what I understand from fibromyalgia, all the research, we currently are probably looking very close to the immune system as a major culprit in this. When we have when we're under constant stress from life events, injuries, pain, surgical experience, or whatever, our immune system will actually get a little bit more activated, if you will, and these little immune molecules, cytokines, will travel through our body. And there are receptors or sensors all over these 45 miles of nerve in our body, and they become sensitized to it. So we developed a widespread sensitization. I remember in the early days, some rheumatologists would talk about the idea that fibromyalgia feels like living with the flu every day. Now, again, I do not have it. I can only go with what my patients have told me. But with that comes the widespread pain, the achiness, the soreness, all the things we see. So first of all, it's a very real condition. If you have fibromyalgia, are you hurting? Absolutely. It is a little bit more complex than just a specific muscle or a joint or a tendon. It's widespread. It will heavily, significantly impact things like sleep and memory and problems with energy. You get fatigued, those kind of things. So the good news today is that we can treat it. We can treat it quite successfully. The current best evidence for conditions like fibromyalgia is definitely some cognitive-based therapy, which just means that we need to have some conversations about your thoughts and your feelings and your beliefs and your fears, which is what you and I are having today. So a clinician would have to deal with that. Movement is essential. It's absolutely essential. Maybe not at a high level. Some lower level exercises on a regular basis, kind of a little bit often kind of an idea. We got to pump some blood through the body, a little bit of oxygen through the body. And I can only imagine somebody on the other side going, but Adriaan, again, when I move, I hurt. Correct. But think of it as getting the much needed nutrition and oxygen and stuff in our body for that matter. And then there's all the other cool stuff, Brent. We can talk about sleep hygiene. Let's work on strategies to have a better sleep routine. There's nutritional aspects we can address. There's pacing, greater exposure. But that combination of let's talk about your thoughts, beliefs, feelings, and work through that. We move you, and then strategies to calm this nervous system down. That is currently the best evidence, and the data is really good. One last comment really about this is, I just want people to know that today in this world, today as you were doing this presentation with this conversation, there are people with fibromyalgia doing some amazing stuff, right? They're starting a business. They decide, I'm going to do my PhD. I'm going to finish my night classes as a nurse. Don't let the condition or the label limit you. Again, we have good days, we have bad days, but what can we do? What can we focus on? There are a lot of people are doing that. Does it mean they live pain-free every day? No, they still have tough days. They have some better days. But if you string some of those days together, we can actually do really well. And the data will prove that. We can definitely help patients along this path.
Yeah, I really appreciate you sharing that. And I haven't heard, it certainly makes sense thinking of the cytokine storm kind of activity through the body, just that irritability in connective tissue throughout. I remember back in the day, there was a pain doctor named Dr. Sam Yu that was out of Minneapolis. And this is way back. But one of the things that he had found also was tied to things like imbalances of relaxin hormone, and also became, and I think that sort of got debunked, but I remember thinking of the intervention that he wanted was for his patients to have multiple small movement sessions a day. And that's how we met, was like, rather than thinking of them coming and doing 2 or 3 hard Pilates classes a week, maybe we get them a machine in their house and they do 5-10 minutes 3 or 4 times a day to be able to get movement in their body, their tissues, and that we saw in a study that he did actually a desensitization or a reduce in that hypersensitization, probably a better way of saying that, in the day that they did it. Not necessarily long term, but that it was a way that they could participate in life much more fully. And we do see a lot of people with fibromyalgia that are able to function well. Any experience as far as pharmacology that you've seen with these patients, whether they're in thinking of drugs that come to mind for this, but neurogenic drugs that are quite often prescribed?
Yeah, well, first of all, obviously, I'm a physical therapist, so that's not my job.
I know it's not, but we see it all the time.
Fair enough. I have pharmacists we work with. I spoke at a pharmacy conference 2 weeks ago. I work with pain docs all the time. The current drugs, if you look at chronic pain in general, and this would include fibromyalgia, the 2 families of drugs that seem to have the best response for us, number one is your membrane stabilizers. because they calm down the peripheral nervous system. And then the second one is our low-dose antidepressants that turns on serotonin in the central nervous system. The bottom line is both of them calm the nervous system down, be it all these 45 miles of nerves or our central system. That those two families of drugs, and within them there are subsets between all the different ones, they seem to be constantly reading. Actually, in Cochrane, they get listed as gold level evidence, which just means stop studying it, we got it. I'm paraphrasing a little bit, but those are the better.
Is that like the gabapentin or Lyrica?
Correct.
Okay.
Yeah, these are your membrane stabilizers, your pregabalin, all those kind of drugs. But, and again, each has their strength and weakness or whatever, but those two families of drugs are typically what seems to be the highest levels of evidence that we have right now for people with persistent pain.
And I will back you up on the fact that we are not pharmacologists. We're not trained in pharmacology, but I do think...
We are trained. We get training in it. We just
we're
don't
trained,
tell people
but it's
to
not
take it or not. Yeah.
Exactly. We don't prescribe medication.
There we go.
There we go. And I think it's important to understand, though, that we want to have a very collective approach with multiple dimensions to it. Like you said, nutrition, sleep hygiene, pharmacology can go a long ways when it's the right pharmacology. And like you said, it has been shown to be a standard. It is accepted. And I just want people to know that are out listening is that they might be on some of these pharmacological treatment protocols, and they often want to know, is this something I should stop doing? Is it harmful to me? It's a question for your doctor. But we need to be able to know that it is a multidiscipline approach often when we're taking care of chronic pain types of syndromes, and fibromyalgia certainly falls into that. Adriaan, is there anything else that you'd want to share to the general public about just your experience in helping to manage, decrease the fear of, restore function as it pertains to chronic pain?
Yeah, I think I've mentioned a couple of it already, and I really want people to know that, first of all, there are a lot of healthcare providers that care, and they really care. I cannot speak for everybody. Like I said, I was probably the other one early in my career. I didn't know anything about anything. So we've never learned as much about pain as in the last 10, 15 years we ever have. So we're trying. The good news is everything we're studying shows us it can get better. It does take some work, no doubt about it. But, find a good provider that listens to you, treats you with respect and dignity. But all these things we're dealing with can shift, and it can shift for the better, which means it can get better. And that's the big part of it. But yeah, there's a lot of people working on it, and we're trying as hard as we can to get some help. The bad news is we haven't done well. The good news is we're doing better. A lot better now. Yeah, the bar is low.
All right. Well, thank you, Adriaan. I appreciate you taking the time and sharing your wisdom with our population. And I think that when we look at the combination of education and movement, creating these positive movement experiences, we do see really good outcomes. There was a study that was produced. It was a systematic review that came out in the British Journal of Sports Medicine, and it had looked at everything for mechanical low back pain, from pharmacological to physical therapy interventions and more. And Pilates came up in the top 3 as a successful intervention. And what I want to say about that is that the idea of having these positive movement experiences, especially with low back pain, I mean, this one was particularly about low back pain, mechanical low back pain, is that the brain, that neuroplasticity you're talking about, changes when we're able to have successful experiences without pain or without increasing pain. And if there's any way that we can help you remove the perception of or the belief that pain is always doing damage, how we can get you to desensitize that. I mean, that's really, to me, one of the key benefits of physical therapy when dealing with chronic pain, what our therapists should be doing, and of course, the education. Adriaan, if somebody wants to find you or get your book, best way to find you, is it through Evidence in Motion?
Yeah, that's the easiest one. Evidence in Motion is probably the easiest place. If people want to go to Why You Hurt, which is a double Y, whyouhurt.com, there's a lot of cool resources there. It's free. If you want to find a provider that we've trained all over the United States in the pain stuff, and there's some nice videos for patients to learn about pain. It's all free on that site, so that's also a great place to go find us.
Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drbrentanderson.com. You can follow me on Instagram at Dr. Brent PT. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned Podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Special thanks to my team, Elizabeth Jimenez, Melissa Pereda, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.